Good afternoon. My name is Sofia Ramirez, and I oversee research communications at the new Osler Research Institute for Health Innovation. It is my pleasure to welcome you here today. To properly begin our time together, we would like to first acknowledge the rich history of the land that Osler stands on, as a way of honoring the Indigenous people that have been living and working here since ancient times. Indigenous people are the original caretakers of this land, now known as Peel and Etobicoke. This is the ancestral territory of the Wendat, Haudenosaunee, and the Mississaugas of Credit First Nation. Much of Osler's work takes place on the traditional territory of the Mississaugas of the Credit First Nation. As visitors to this territory, we at Osler would like to express our gratitude to the Mississauga peoples of the new Credit First Nation, the descendants of the Credit First Nation. Osler would also like to respectfully acknowledge the diverse community of Indigenous peoples representing a multitude of distinct nations who currently live, work, and play on this territory. We would like to express our commitment to honoring Indigenous communities and nations across the territories now known as Canada. Thank you. And now I'd like to introduce Patty Rempel, the Director of Clinical Research at the new Osler Research Institute for Health Innovation. Thank you.
Good afternoon. It is my privilege to welcome you to this event. This is the third event in our speaker series, and today focuses on a clinician researcher undertaking important research in critical care medicine at the Osler Research Institute for Health Innovation. Through this speaker series and our public events to come, we hope to give our community a view behind the scenes. A significant upcoming public event is Celebrate Research Week, taking place between November 18th to 22nd, where we will formally launch the Osler Research Institute for Health Innovation and showcase the excellent research underway at Osler. However, Celebrate Research Week is not just about Osler and has been proclaimed by the City of Brampton as a regional level event in which the community will also host events. You are all invited. Stay tuned for your invitations and information about the ways you can host your own events to celebrate research. At the Osler Research Institute, one of our primary goals is to address the healthcare priorities of our patients and community by providing early access to novel interventions leading to improvements in patient care, health outcomes, and systems performance. Today's conversation is a perfect example. Now, let me introduce our host and researcher for today's discussion. I am pleased to first introduce Pachin Baras. Pachin is a scientific journalist that has written, edited, and produced stories for many recognized publications such as Nautilus Magazine, Scientific American, and has also been a producer at CBC Television and the Discovery Channel. His most recent work, the first biography of Nobel Prize-winning physicist Roger Penrose, will be released in November. We are also thrilled to introduce Dr. Alexandra Binnie, a distinguished critical care physician and physician lead for ICU research at Osler. Dr. Binnie focuses on the pathophysiology of sepsis and multiple organ dysfunction syndrome, particularly the role of epigenetics in inflammatory responses. A co-founder of the Canadian Community ICU Research Network, she's been pivotal in enhancing research capabilities in community hospitals. Welcome, Dr. Binnie and Pachin. We look forward to your conversation.
Thank you so much, Patty. It's a great pleasure for me to be here again. I've participated in a couple of earlier discussions in this event series, and every one of them has been fascinating with really interesting, accomplished people. I'm sure today will be the same. I thought maybe we could start with the question of maybe, Ali, you could talk a little bit about how you first became motivated to work in critical care medicine and how that brought you to Osler and how your role has evolved there as the ICU research lead.
Absolutely. So first of all, thank you for inviting me to do this, and hopefully it'll be interesting to talk a little bit about these issues over the next 45 minutes or so. So I actually came from a research background. So after doing my undergrad in immunology and genetics, I did a PhD in molecular biology. And so I sort of started on this route thinking that I was interested in research. And then I took a bit of a turn at the end of my PhD and decided that I wanted to do something that was more immediately applicable to human health and treating patients, and that being in the lab was a bit too far removed. And so I then doubled back and went to medical school. And so I always sort of had the idea that I would do something like oncology because it seemed more relevant to my research background. But when it actually came time to start treating patients, I found that I really liked critical care, and the reasons that I liked critical care were well, there were a number of them. First of all, critical care is really a team sport, so you work in conjunction with not only other physicians but nurses and respiratory therapists, and I think there's a really lovely team environment in critical care where you feel like everybody is sort of nobody can function on their own. A doctor is not much use without nurses and respiratory therapists, and same vice versa. And then the problems are very interesting to me because in critical care, what we see is people's hearts failing, or their lungs failing, or their kidneys failing, and all those problems end up interacting with each other. So you're always trying to sort of manage the physiology of the person, which in other areas of medicine, we maybe don't see that as much, the kind of true physiology behind how the human body works. So it was very interesting to me. And I also, it's a very compelling area because the stakes are very high, right? People are very sick, and a lot of people pass away in ICU, and sometimes our main job is sort of counseling people as to whether ICU is really a good idea for them, because we know the reality of what it's like to be in an ICU, and maybe we don't have a lot to offer. So that's another kind of challenging aspect of what we do, trying to help counsel people as to whether ICU is something that's really going to help them or their family member. So those were some of the reasons that I went into ICU. And then when I finished training, I initially worked in internal medicine for a while, but I knew that I wanted to do ICU. And a position came up at Osler, and I didn't know Osler. I hadn't done any training there. But I liked the fact that it was a big suburban hospital system with a lot of patients and a lot of interesting cases. One of the things that's interesting about our Etobicoke site is that we get all of these people off the airplane. So whenever you get the overhead announcement on the plane that someone's sick, and is there a doctor on board, that patient ultimately finds their way to the Etobicoke General Hospital emergency room. So we see some sort of interesting cases. We also have a very diverse local population, both in Etobicoke and Brampton. So we see a lot of interesting cases and a lot of complex cases, and I think it's a lovely hospital in terms of the team that we work with, and so all of those things I think fed into the decision to come here. But at the time, we had no research program, and I hadn't really had the ambition to start one. But then Andrew Healy, who was our critical care director at the time, sort of said to me, "Hey, Ali, what do you think about starting a research program?" Hint, hint. And so that was kind of how things got going, because I was really from a basic science background, not from a clinical research background, and the two things are a bit different. So,
and well, I mean, that's exactly what I'm struck by in how you describe that story is you have this, at least in the popular imagining, and I think it is actually this way. In critical care, you're dealing with things very much in the moment. This needs to be dealt with now. This is urgent.
Yeah.
This is something that has to be dealt with right away. And then in terms of basic research, that's a process, and often you're thinking about questions that will take years to answer or even longer. And I wonder if you could talk a little bit about at Osler how that relationship works between how research informs the patient care that you're giving, how you use what you're learning from patient care to inform research. How does all of that fit together with those two quite different types of streams?
So I guess the first thing to say is that in clinical research, in order to prove anything in clinical research, you need very large numbers of patients. So you're never doing something in isolation at one hospital. And that's one of the reasons, I think we'll get to this later, but that's one of the reasons why it's so important to get as many hospitals as possible participating so that you can actually come to some conclusions that are helpful. But I think you're right. There is a funny contrast. I hadn't thought of it before, but between the sort of pace at which we have to make clinical decisions and the time it takes to change what we understand about those decisions. Because even I mean, lab-based science obviously takes years, but clinical trials take years, right? It takes us years to recruit enough patients to actually come to some sort of conclusion. And the better we get at critical care, the larger these trials get. So it used to be that critical care trials were 300 or 400 patients. Now they're 3,000 or 4,000 patients. And you have to get patients that all fit a certain set of criteria in order to enroll them in the trial, in order to be able to then jump to some sort of conclusion. So, so there is a funny contrast, and it also complicates doing trials, because if you can imagine, if you're enrolling for an oncology trial, the patient might come to an appointment and you might say, okay, you have this type of cancer and these characteristics, you would be eligible for this study. Here's some information. Why don't you go home and think about it? And in a month, when you come back, we can talk about enrolling you in the study, or in 2 weeks or whatever. In critical care, we need to enroll the person now, because now is when we need to treat them. And so that's led to a lot of, there's a lot of efforts to try and, because you still need to obviously take into account the person's autonomy in deciding whether to participate or not. But those two things are in direct conflict with each other. Like, I need to recruit you now if you're going to be in this study, but you also need time to think about whether you're going to be in the study or not. So that's sort of one of the issues that critical care research is contending with at the moment. And there's a few ways that we're getting around that, but it's but you're right, there is a funny contrast between the pace of research and the pace of critical care. They're quite different. Yeah.
And so maybe I'm going to ask a pile more questions, but I'm just going to pause for a second to say to the audience that we'll be taking some audience questions, as many as we can get to as well. And the place to put them is in the Q&A as opposed to the chat in the Zoom function. So feel free at any point when we're doing to add some questions there, and we'll try to get to them as we go. And now to come back to this conversation, there's this very interesting juxtaposition of those two things. I wonder if maybe we could look at the pandemic, the COVID-19 pandemic, I think, was, among many other things, it was a huge challenge from a critical care perspective, and but that also came with it maybe a chance to work or to develop some to essentially as a crucible for what we were just talking about ways you could use that crisis to further research, and how you could apply emerging research to improve patient care that you're giving. And then if you'd be able to talk us through what that experience was like, and how that played out at Osler. Yeah.
So well, everybody's familiar with the pandemic. There's no need to explain how big a crisis it was in healthcare, but there was a need. So going back to SARS-1, SARS-1 was a bit of a failure at the research level, because everybody was sort of treating higgledy-piggledy with whatever they thought might work. There were no studies set up formally that managed to actually complete enrollment before the pandemic ended or the epidemic ended. And so there was almost no usable data other than observational data out of SARS-1. And as a result, people started thinking, and then there was H1N1 that ran a bit of a similar course. And so then people started thinking, well, we need a more formal structure that will enable us, when something like this happens, to actually run studies quickly and come to some sort of usable conclusion about what we should do to be treating these patients. Because otherwise, these diseases come, and in the case of COVID, they stay, and we may or may not have good information about how to treat them. So there was an attempt to set up a study called REMAP-CAP, which the people in our ICU are very familiar with, which is a study of respiratory illness. And they were waiting for the next influenza pandemic, basically. And the idea was, if we have a study that's running permanently and that's testing treatments in run-of-the-mill pneumonia, when a pandemic comes along, we can immediately sort of change course and test things in this new pandemic illness without having to go through years of approvals and protocol writing and all the rest of it. So that worked, actually. Ironically, REMAP-CAP was set up about a year before COVID hit. And so as soon as COVID hit, within a month or two, they had a COVID protocol and they were enrolling patients with COVID. But at that point, it became apparent that Canada had a bit of a problem, which is that the largest number of COVID patients were being admitted and treated in peripheral or community hospitals. So hospitals like Osler, Scarborough General, Markham Stouffville, Trillium, all of these hospitals in the periphery of big cities, and the same thing was happening in Vancouver and Montreal, and then areas like Windsor, where it's just there's a very large community hospital system in Windsor. And they were receiving the bulk of the patients, but they don't do research. So when patients walk in the door, they weren't having, you couldn't access those patients to either offer them research or include them in your studies to try and understand what was working and what wasn't. And a lot of the patients that were coming into the Toronto General, for instance, were already a week into their admission, and now they had deteriorated and they needed even more advanced therapies that were only available there. But you've already missed your treatment window by that point, right? By that point, you're looking at these advanced sort of rescue therapies and your initial treatment window is gone. So it became apparent that we needed the ability to do research studies and test therapies in these more peripheral hospitals. So there was suddenly a lot of interest in bringing on board these community hospitals. And Osler was very fortunate in the sense that we already had this pre-existing ICU research program. And at the time, our research director, who was a lovely man called Ron Heselgrave, he had been sort of helping us set up our research program. And then when COVID came along, he said to me, listen, I think we need to run COVID studies here. I think it's very important that we run these studies. And I want you just to run them. We're going to make it work. I don't, and at the time I didn't know it, but Ron was very ill himself. And a lot of our initial conversations setting up COVID studies took place with Ron in his hospital room and me on the other end of the phone and trying to get these studies running. And so we ended up being able to set up a number of COVID studies, both in the ICU and on the wards. And we recruited enormous numbers of patients, and it had a lot of benefits. One, from a research perspective, it was great because we got a lot of patients into these studies. We learned an enormous amount about COVID. It contributed to a number of the main articles about that determined how we treat COVID now, included patients from Osler. The second thing was that our patients got access to treatments that they wouldn't otherwise have had access to. So for instance, we had access to remdesivir quite early on. We had access to tocilizumab. We had access to these stem cells that we tried in a trial that seemed to have been extremely helpful. And so we were able to offer things to our patients that we might not otherwise have been able to offer, or that we might not otherwise have been able to offer as early as we offered them. And at the same time, we were able to help get rid of some of the therapies that weren't working, but that in the popular news were being promoted, hydroxychloroquine and this sort of thing. We contributed to getting rid of those therapies and avoiding any sort of unfortunate side effects from them, and avoiding the cost of giving, useless therapies to people. So I think all of those things were really beneficial, both for Osler patients and for the hospital itself. And then I think there was the additional part of, when you're in that sort of situation and things feel a bit hopeless, and, in the ICU, we were really overwhelmed, as were the wards. I think it's a little bit comforting for the healthcare staff to feel like, okay, well, at least we're learning something, and maybe things will be better in 3 months or 6 months because of what we're learning today. So today we don't really know what we're doing. We're doing our best. At least we're getting information. We're trying to figure out what works. And that means that in a few months, maybe we won't be in this same situation that we're in right now. So at least personally, I think it was very helpful from a psychological perspective to feel like we were doing something to improve the situation.
And can I ask on that front, where we are now, COVID is still highly present, and there are lots of fears of other viruses stepping into the breach. Do you feel like the research that happened during that time of extreme crisis puts you in? Are you better prepared now? Do you have more knowledge, both about patient care and maybe if there is a new wave or a new pandemic, about how you might be able to make your learning even more effective as you go through with that? Were there things you learned as you went through that experience?
So I think from a disease perspective, COVID, as everyone is aware, has really settled down, and it's settled down even more from a critical care perspective than in the general population, in the sense that we see very few critically ill COVID patients now. I think virtually everybody in the population has had it at least once. The more recent strains seem to be less virulent, which was sort of what the virologists were telling us at the beginning, was that the expected evolution would be that it would become less virulent over time. And that has certainly happened. And I think the herd immunity is sufficient that we just don't see the same level of illness that we did at the beginning. We certainly know how to treat it now, although the people that we see with very severe COVID tend to be people that are immunocompromised for one reason or another. And those patients don't always follow the expected course and can still get very sick. And unfortunately, because they're such a specific subpopulation, our studies don't necessarily apply to them. So we have to kind of extrapolate from studies of immunocompetent people to decide what we're going to do for an immunosuppressed person. And that's just has to be based on sort of expert opinion, because it's hard to run studies when people have very specific characteristics, right? In terms of research, I think we learned an enormous amount, and really the shining example of what to do, not from a public health perspective, but from a research perspective, was the UK, where they have research in every community hospital in the UK. So they have a system, which some people may have heard of, called the NIHR, where the government the health system sets research priorities. Once a study is approved in one hospital, it can be rolled out in every single hospital across the country. And so I think they have about 200 and something hospitals in the UK, and they had 176 of them recruiting for their main COVID study within weeks. And they recruited 10,000 patients within 3 months. I mean, it's just unbelievable, like sort of orders of magnitude beyond what anybody has ever done before in a clinical study. And Canada, I think we got better as we went along, but we didn't have that type of pre-existing infrastructure. And I think now part of our problem is that our way of funding healthcare is quite different from them, right? They have sort of a centrally funded healthcare system where the hospitals are funded directly by here our hospitals are all sort of little independent fiefdoms that get government funding, but they're all separately run. And the money for healthcare comes from the province, but the money for research comes from the federal government. And so there's a lot of sort of logistical issues here that are more difficult to circumvent. But I think it certainly shows us kind of what we ought to be able to do to respond to future pandemics. And we're slowly making incremental steps to make that more of a reality here, but we do have some barriers to that are challenging.
Well, let's broaden out that conversation a little bit and talk about one of the reasons why we're having this conversation is because of the unusual nature of a community hospital being so deeply involved in research. And I wonder if you could talk a little bit about what sets a community hospital apart from an academic hospital or another hospital in the broader research landscape, and what the kind of innovations that you're doing at Osler to bring research into that world, how that changes the game.
So those are very good questions. So by pure definition, an academic hospital is a hospital that's fully affiliated with a medical school. So in Toronto, you'd be looking at Toronto General Hospital, Mount Sinai, St. Michael's. There's a number of teaching hospitals in Ottawa. There's a teaching hospital in Thunder Bay. And historically, those hospitals have been very invested in research. But it's not automatic in the sense that, Health Sciences North in Sudbury and the hospital in Thunder Bay are both academic hospitals, but don't actually do that much research. Community hospitals can be partially affiliated with medical schools, and increasingly a lot of medical education is being decentralized and moved out into community hospitals to varying degrees. So more and more community hospitals have medical students. And historically, community hospitals didn't do research, but there are pockets of research. So you could have a community hospital that does more research than another academic hospital, right? So these definitions are quite gray. So, for example, the Osler Oncology Research Program has been around for quite a while and is very developed and has done a lot of studies over time and has a lot of expertise. So that's a great example of kind of a pocket of research expertise in a community hospital. However, I think most people would be able, if you said to them, do you work at a community or academic hospital, they would kind of know automatically which they're in, even though the distinctions between them are a little bit vague. So the advantages of broadening research into community hospitals, there's various advantages. You can sort of think about them as like the advantages for the patients and the advantages for the institution. So So for the patients, like I was saying, with COVID, you get earlier access to cutting edge therapies. So, in oncology, it's very easy to see how that's important, right? These novel, therapies are only accessible within within clinical trials, and you just can't get access to them unless you're in a clinical trial. And if you live in Brampton, it may be easy for you to commute to PMH, but it may not. And being able to access that in your own center is a huge advantage. So that's one thing. The second thing is that I think it helps us to produce research results that are more generalizable, right? So if you're only recruiting patients in downtown Toronto, you're going to get a certain cross-section of the population, but that's going to be a different cross-section from the population in Brampton or in Windsor or whatever other location you can think of. And so by broadening clinical trials, you're actually including the broader Canadian population and hopefully getting a more representative population. And we've actually done a couple of little studies looking at who are the patients in academic hospitals and community hospitals. And the patients in community hospitals are older, they're more frail, they have more comorbidities. We don't have specific data on ethnicity or immigration status, but based on geographic location, one would imagine that they're more diverse communities, more people who are recent immigrants. We do know that there are socioeconomic differences between people that go to community hospitals and go to academic hospitals. So there are some really important differences that could actually affect the results of your study if you're only recruiting from one type of hospital. So that's the kind of patient side of it, that we're getting better quality data that's actually relevant to our patients, and they get access to therapies that they might not otherwise get access to. The hospital side of it, I think, is multi faceted. So on the one hand, it's good for the hospital in terms of creating connections to other hospitals, in terms of bringing in, more cutting edge therapies, in terms of generating recognition. I think it's also very good for hospital staff, because even outside the context of COVID, it's good to feel like you're not just repeating the same mistakes that you've repeated for the last 10 years, that you're actually evolving and doing things better and learning, and every year is a little better than the year before, and that you're contributing to that process. And then I think there's a much faster knowledge translation when people are involved in studies, right? So if you're involved in helping recruit patients for a study, well, then you're automatically interested in the results of that study, and you are aware of the subtleties of those results. Like, okay, well, we tested this, but we didn't actually include that patient population. So how am I going to understand the use of that therapy in this particular subpopulation? And the complexities of it are much more apparent to you because you actually were involved in the study. And I think it elevates the conversation a little bit in terms of people's understanding of what they do in clinical practice. And then I think it also contributes. In fact, there's studies from the US suggesting that it contributes to staff engagement and retention and that sort of thing, which I think just comes down to kind of atmosphere. People feel more engaged.
Sure, it makes absolute sense. And can I ask, I feel as though Osler is it's kind of a leader in this area. And can I ask about the research toolkit that you've been involved with, and talk about how you might bring the model at Osler to other community hospitals around Canada or maybe around the world? I'm not sure exactly where.
So the toolkit is something that I put together with a few other ICU colleagues from other community hospitals, and it's meant to be a toolkit, but a sort of a set of instructions / suggestions to help people launch their own community ICU research programs. And it came about because I a few years ago, along with a colleague at Niagara Health, which is another community hospital, we started something called the Canadian Community ICU Research Network. And we started it because the two of us were trying to build research programs in community hospitals around the same time, and we're encountering the same barriers, and realized that there were a lot of things that we had in common that it was easier to sort out if you had someone else to bounce ideas off. And undoubtedly, individual hospitals have their own idiosyncrasies, but there's a lot of things that don't exist in community hospitals, or that need to be thought of in a slightly different way in community hospitals, that it's helpful to have some support from other people that have been through that experience and haven't just walked into an ICU that has a long-standing research program and a large research staff and the expectation that you're going to be doing research. So we made this community ICU research network, and it had already sort of gained a little bit of momentum, and then COVID came along, and suddenly everybody was thinking, well, why aren't we doing research in our ICU? This is a lost opportunity. So that generated a lot of enthusiasm and interest. And so the network has kind of grown, and we now have people from, I think, about 40 hospitals across the country that come to meetings and participate in our annual symposium. And to give you a sense, like a large critical care trial in Canada would recruit from about 40 hospitals. So to add another 40 hospitals, albeit probably smaller on average than the academic hospitals, but to add another 40 hospitals is an enormous number of centers. So those hospitals have become increasingly engaged. And actually, I was just looking recently at one of the site lists for one of the large ICU trials that's taking place right now, and about half of the sites on that list are community hospitals. So there's been a real transformation in terms of community hospital involvement in research. So we made the toolkit to try and help provide some information, because there's sort of nothing out there to help people set up community research programs. And it says, I think it's called the ICU toolkit, but it's really meant for anyone doing sort of acute care in hospital research, which is quite different from outpatient research. So that was what it was meant to address, was that gap in information. And it's designed to be very sort of readable. It's all kind of question and answer, FAQ type format, and sort of different sections set apart. And it also has an area for people to make suggestions if they think there are things we should add or amend, so it's meant to be kind of an evolving document. Yeah.
It sounds like it's been very well received. It sounds as though this is something that is making an impact as it goes.
I think so. We're getting more and more requests from people in further flung parts of the country, because the hospital research, we actually just did a survey of sort of community hospital publications from across the country, and it's very centered in Ontario. So Ontario has a number of large community hospitals, and that undoubtedly is driving it, but it's also, for whatever reason, has become a center for community hospital research compared with other provinces. There's a little bit in Quebec, more and more in BC, some in Alberta. But we're starting to get more and more emails. I get these emails on our CCIRnet email account from people saying, hey, I'm at such and such a hospital. I'd love to think about doing research here. Can you put me in touch? And so we sort of bring them into the fold, and we get them onto the toolkit, and we get them to come to meetings. And we're seeing these sites kind of pick up one by one across the country, which is really amazing to see. And I think it's incredible how, I got a message the other day from someone in Nanaimo, and then I got a message from someone, I can't even remember the name of the hospital. It's right at the border, at the US border in the interior of BC, Trail, British Columbia. And so we're sort of seeing these interests from these very interesting pockets all the way across the country. It's really cool to see people sort of taking an interest and then thinking, well, maybe I can do this, maybe it's not out of the question for working in a community hospital. So
right. And you mentioned the differences with the UK, but are there other places in the world that have this kind of divide that can be overcome to bring more community hospitals into the research community, or is that beyond?
That's a very interesting question. I think the academic community model is a more North American model. I think other countries in Europe, for instance, have a more distributed medical education model, where the medical students might be in certain hospitals, but the residents are kind of spread across the country. Australia and New Zealand do have a bit of an academic community divide. But what's interesting there, particularly in ICU, is that they long ago got over that divide by basically creating a group that was meant to be a research group for the whole country and getting all of those hospitals into research studies. So people who are outside the area of ICU probably don't know this, but there's something called the ANZICS Society, which is the Australian New Zealand ICU Society, and they run some of the biggest critical care trials in the world in Australia and New Zealand, which don't have that substantial a population. I mean, they're smaller than Canada, and they're running together, and they're running these enormous trials because they have, whereas Canada might have 40 or 45 ICUs traditionally participating, they can pull together 80 in a country with half our population. So
Right.
so they got over it. But again, they have a more central funding model, which I think is helpful in terms of, they're actually putting money into ICUs to get them coordinators. And in Canada, that's hard to do. The money kind of has to come through other channels. So yeah, I think the US is another interesting example. They definitely have an academic community divide. I've heard that there are some community hospitals in the US that are very heavily involved in pharmacy, like industry funded research, because industry funded research is much more remunerative in terms of paying the costs of the research itself, and hopefully having a little bit left over to help fund the research program. Most of what we do in ICU is what we call investigator-led research, which is very poorly funded, and we're constantly sort of scraping the bottom of the barrel to try and keep our studies running. But apparently in the US, there are some places that really have gone heavily into industry-funded research.
That is leads into one of the questions that's coming from the audience, and a reminder to the audience that if you have questions, to put them in the Q&A. But there was a question, I don't know if you want to wade into this, but there's a question: how would you change the way healthcare is funded, or change the health system so that the kind of these two streams that you're trying to further together, how would you structure it so that you could facilitate those things?
Well, I'm not going to wade into how healthcare is funded, because that sounds like a terrible, a terrible quicksand. But in terms of research funding, I mean, I think to me, the healthcare system should be what we call a learning health system, right? Where every patient encounter contributes to information that then makes the whole model better. And achieving that, of course, saying that is one thing and achieving that is another. And I think that, as we move into the era of artificial intelligence and large data set processing, that becomes more realistic if hospitals sort of have giant data sets that are constantly being updated, and algorithms can be applied to try and optimizing patient encounters and optimize functioning. But even putting that aside and just focusing on clinical trials, we're always going to have clinical trials in order to test something. At the end of the day, does this really work? And we need to prove that it works before we say everybody's going to get this treatment, right? And ideally, every patient that was eligible for a study should go into that study, because if the study is allowed, it's because we don't actually know which is better, right? And if we don't know which is better, then the best thing we can do for our patients is put them in the study so that half of them get whatever turns out to be better, and only half of them get what turns out not to be as good. And then after the study is finished, everybody from there on in gets the best treatment. So in an ideal world, from a pure research perspective, we would put as many patients as possible into studies, and we would test everything, because there's a lot of things we do in medicine that we do them because we've always done them. And we think they work, but do we really know they work? Well, some things are dubious. But in order to do that, particularly in smaller hospitals, you actually need research infrastructure, and hospitals have a budget that's meant to pay for their clinical infrastructure and therapies and whatever, and that money is not designated to run a whole research infrastructure. And so the way that research studies are funded is that the hospital basically gets paid a small amount of money per patient that they enroll in the study. So it's meant to incentivize recruitment. So rather than putting in a whole research team and then having them not recruit any patients, which would obviously be very inefficient, it's meant to incentivize recruitment. The problem is that it works well if you have a pre-existing research infrastructure and you have lots of patients. But if you have a small hospital or a rural hospital, or you've never done research before, and suddenly you're just going to get this little tiny payment for each patient, well, how are you going to pay to train your coordinators? How are you going to pay to learn how to do this? How are you going to pay to set up a research ethics board? How are all of those things are unfunded, and so you either need someone with sort of a vision that this is important for the hospital to get things going, and the hospital has to find some money to underwrite that, or you need funding from outside. And currently, there's really almost no funding from outside. So I think COVID gave people in community hospitals the idea not only that they could do research, but that it was important to do research, but it still hasn't solved the financing problem. So to my mind, the government should recognize this as a priority and should be providing targeted funding to put research teams into hospitals and further research in hospitals. Whether that's a provincial responsibility or a federal responsibility, I don't know, but I think that there ought to be funding for some sort of national research network that recognizes what our national health priorities are, and maybe our health priorities are treating diabetes in outpatients, or maybe they're, I'm not trying to specify what those should be, but I think that there should be some thought put into it and some effort to put something together.
Well, speaking of specificity, another audience question was, what are there any studies that you're working on right now? Are you able to talk about anything that you're looking into in terms of technologies, treatments, medications that you're exploring or developing now through your work?
Oh, can you hear me?
Yep. Okay. I think
I just missed the question. Sorry, just ask it again.
The question, essentially the question was, what are you working on right now, research-wise?
Oh,
What
okay.
are innovative technologies or treatments that are in the hopper?
So currently we have a few studies going. One is a study, it's that REMAP-CAP study that I told you about before. And REMAP-CAP is continuing to try and optimize treatments for pneumonia. And so we have, we're comparing different antibiotic regimens, and that's more of a kind of, we do A, B, and C, and which of A, B, and C is better. So that's kind of a understanding better what we currently do and whether one of our options is a better option than the other. And then they're also looking at influenza and some of the treatments we apply to influenza pneumonia, and whether we can improve how we treat influenza pneumonia, which we haven't had a lot of influenza in the last few years, but influenza always comes around again, and we do need better information about how to treat influenza. So that's REMAP-CAP. Then we have another study that we're just starting, which is looking at how we ventilate patients. So when patients are very ill and they require support for their breathing, we put them on mechanical ventilators. And a lot of what we do with mechanical ventilators is based on animal studies, and not actually based on trialing things in human beings. And so they're trialing a new way of setting the ventilator. And basically what we're trying to do is we know that ventilators, in addition to saving lives, they also damage lungs. So the lungs are already damaged, and then you're applying all of this positive pressure, and that in and of itself, by stretching the lungs, is damaging if it's done wrongly. And so we have certain ideas about how we need to set the ventilators to minimize this damage and protect the lung as much as possible. But there's now a notion that we maybe need to set it slightly differently and use a different set of parameters, particularly if the patient is doing some breathing on their own, that we might want to actually adjust how we set the ventilator. And also if the person has very stiff lungs versus very elastic lungs, we might want to set the ventilator differently. So we're doing a study that's looking at that issue of how to set the ventilators most safely. And then the results we're looking for are how long the patients are on the ventilator, and also mortality. We're doing another study trying to understand the genetics of a type of diabetic ketoacidosis. So there's a medication that a lot of people take called an SGLT2 inhibitor. And people on those medications, most people on those medications are fine, but a small percentage of people come in what's called diabetic ketoacidosis, which is where their sugars, well, ironically, with this particular medication, sometimes they don't go high, but basically their sugars go high, and then they don't have enough insulin on board, and we have to put them on insulin infusions and get their sugars back under control. And this medication is associated with that side effect. And you can also have a special form of that side effect where the sugar doesn't go high, but all the other things happen. And so we're trying to understand if the people that have this reaction have a certain genetic predisposition to that reaction. So we're getting samples from cheek cells of people who have that reaction, and those samples are being tested to see if that's if there's a genetic predisposition. And then we have another study where we're testing in COVID still, and we have very few COVID patients, but there are a handful of COVID studies still running, where we're using a special blocker of what's called the innate immune system. It's an antibody medication that you just get once early on in your COVID course. You have to be very ill. You have to be on a mechanical ventilator. That medication is given as a one-time dose, and it's meant to sort of tamp down the immune system to see if we can, because one of the issues with COVID, as you probably know, is the inflammation is out of control. And so a lot of our treatments are anti-inflammatory medications, and this is a slightly different type of anti-inflammatory medication.
Fascinating. I want to try to combine a couple of questions that have been coming in. There have been some questions. You touched on the challenges of enrolling people who are in critical care in research studies, and I wanted to talk about both the ethical challenges and the logistical challenges of people who might be in crisis, people whose families might be in turmoil as well. How you go about how you approach that in your research.
Yeah. So it is a real challenge because on the one hand, people need time to think about these things, and because it's always a crisis when someone comes into the ICU, they're automatically distressed and emotional and upset and concerned about their family member, and to have the research coordinator sort of drop into the room and say, hey, by the way, do you mind looking at this 10-page consent form is not ideal, and I think a lot of time people just feel overwhelmed. So had it been a more relaxing day and they hadn't been in crisis, they might have felt like it was a good idea, but they just can't even wrap their minds around it. They've got too much going on, and so that's one side. And then the other side is, as you said, we need to recruit people very quickly because what we're trialing are urgent acute treatments, right? So treatments for something that is unrolling, in front of our eyes, and we need to institute the treatment now if we're going to institute it. And if we wait 3 days, well, we've missed the window. So one of the things that's being done in ICU trials now, although it's a selected subset of trials, but one of the things that's being done is that we're trialing something called deferred consent. So deferred consent, it's only used when the trial is relatively benign. So for instance, with this ventilation study that I was talking about, we don't know which of the two styles of ventilation is better, but we also don't think that they're going to be very harmful. We don't think that one is going to be particularly harmful. It's not completely outside the realm of what we currently do. It's just a slightly different approach. And so when the study is like that, where the risk of harm is quite low, the ethics boards are asked to approve something called deferred consent. And in deferred consent, basically the patient gets enrolled in the study automatically if they're eligible. And then we have a window of 2 to 3 days in which we need to then get consent from the family. And the theory is not only is the intervention not that harmful, but if the family feels that it's not in the best interest of their family member to continue, we can stop the intervention within a couple of days, and that reduces the harm still further if there is any harm, which we think the harm, if any, is minimal. So that's the approach that's been taken. It's obviously an approach that puts a little bit more weight on the benefits of research to society as a whole, because we are doing something without necessarily the knowledge of the patient immediately. But on the other hand, we have no other way of studying these things unless we can get people enrolled. Now, if it's something that has risk of harm, like a novel therapy, then it would never be considered, because there the family really needs to, or the patient, if the patient's awake, really need to be aware that there are risks associated with the trial and to make a decision about whether that's something they want to do. But with these lower risk things where we're trying to optimize what we do and we're effectively comparing two options that we would do, we just don't know which is better, then this model of deferred consent is being used increasingly.
Interesting. Very interesting. We only have time, unfortunately, for a couple of more questions. There's one here that again, I'm not sure if this is your area of expertise, but someone was asking, what role do you see for AI or machine learning? And I will say, as someone who writes a fair bit about artificial intelligence, one of the places where even the people who are the most critical of artificial intelligence tend to say, yeah, but there's potential here, is in medical diagnosis, customized treatment, identifying issues, and those sorts of things. Is that something that plays into your research at all, or is that still off to one side?
No, it does a little bit. Not so much in what we're doing at Osler. I'm interested in AI to help do some of the legwork. I think using AI for diagnosis is probably quite a way in the future, because first of all, you have to generate the AI programs, and then you need to apply them, and then you need to prove that they work. So then you need big clinical trials to prove that this is actually better, and then you need to stop the AI from coming up with its own ideas over time, right? Because AI is in constant evolution, and so what seemed to be sensible this year, by next year, is no longer sensible. So how do you know that you still have something that works? So it's very complex, I think, to apply it to actually diagnosing and treating the patients. But I think there are much simpler ways in which AI can be very useful. So particularly, for instance, with research, when you're dealing with massive amounts of data that's all in text format, right? So I have a project at the moment where we're looking at using AI to basically sort through databases and pull out, okay, here's patient A, what are their comorbidities, right? And that sounds like it should be easy, but it's actually very difficult, because I might write, oh, the patient has Hep B, and you might write they have HBV, and someone else might write they have hepatitis B. And none of that's in a list format that I can easily put into a table. It's all buried in the text somewhere. And then another person might write, about the patient next door does not have hepatitis B, right? So if I just search hepatitis B, then I get that patient as if they have it when they don't have it. So AI can be enormously useful in actually trying to identify patients, identify information on those patients, turn it into a format that we can then do statistical analysis on. So I think there's actually enormous scope for using AI to help sort through some of our data. Enormous scope for using AI to, for instance, put together past medical histories for us, right? When a patient comes in the door, we could potentially have an AI bot that goes and searches through all of the data on the patient, all of their records in Connecting Ontario or whatever, and puts together a past medical history that's very concise and very correct and very time delimited and whatever. And that would be an enormous time-saving thing for physicians, right? Huge. So I think there's lots of ways in which we can use AI that fall short of actually diagnosing and treating the patients, because I think that's going to be quite tricky to apply it, but that can save us an enormous amount of time and maybe free up people's mental energy for actually doing what's important, which is, talking to the patients, looking at the patients, trying to understand what's going on currently. AI, I think, also is going to be enormously useful in analyzing these giant data sets of patients, these enormous data lakes that people are making to try and understand where the patterns are, and come up with ideas about things that we could maybe look at more in depth. I've heard stories about a study, you may know about the study, where they were looking at retinal scans of patients, and they noticed that there was an association between the retinal scan and Parkinson's disease. I mean, these sorts of associations that no one would ever look for, but AI actually finds them, because AI doesn't care about whether something makes logical sense or not, right? It just looks for associations. And so I think obviously AI has a role to play in there. So I think AI definitely has a role to play in very specific areas where we can kind of manage its output and be certain that it's not making mistakes. And yeah.
So I think maybe it would make sense to wrap up with a question about maybe just looking ahead a little bit. If talk about what your hopes or your expectations are for where research at Osler goes, and the kind of the impact on the Brampton community as well, if you can just give your ideas of where it's headed.
Yeah. So I think there's a lot of things that Osler has a lot of potential as a research center, for a number of reasons. I think we already have a pretty established program of clinical trials, which are usually led outside Osler, right? So they're being led from Toronto General or the US or by pharmaceutical companies, and we help enroll patients, and we learn a lot from that, and we also get the benefit of offering these trials to our patients. So I think that area is established, certainly in some departments like oncology, cardiology, ICU. Some departments are doing a lot of that, and that's great. I think in the future it would be good to see more homegrown research. which means actually, you know, research that's led by people at Osler, where they're getting the funding for the research and then recruiting other sites to participate. And that's quite a big jump from being a site to being the central site for these studies. And I don't think it's something that's going to happen overnight, but I think it would be great if we could move in that direction. And one of the advantages of moving that direction is that I think we can focus on the things that are relevant to us, right? So every hospital has things that are more relevant to that hospital. You know, one of the things that I think is particularly relevant at Osler is cardiovascular health. We have lots of patients with diabetes, lots of patients with cardiovascular disease, and it would be nice to see homegrown studies that are focused in those areas, right? Helping to sort of move things along in terms of our management of those issues. And that's one of the great things about setting the research agenda, is that you can actually focus on what you have locally in terms of your patient population and what your patient population needs. So that would be a great thing to see. And then I think it would be great to see other departments coming on board rather than the ones that are currently doing research, but see more research in kind of acute care medicine, more research in other subspecialties of medicine, and see more research that's being led by nurses and respiratory therapists and other healthcare providers who may not traditionally have done as much research. So I think there's lots of scope for expansion, and there's certainly lots of interested people and excitement. There's a lot of challenges, but I think there's some great things in our future.
Well, thank you very much. I was correct at the beginning when I expected this to be fascinating. It's really there's so much in there to think about, and I really appreciate you taking the time. I'm sorry that we didn't get to everybody's questions in the Q&A, but we're out of time, so I'm going to pass things back to Patty to wrap up this event. Thanks to all of you.
Thanks so much, Patchen.
Thank you so much, Dr. Binnie and Patchen, for a great discussion, and to the audience for their questions. I want to highlight a few learnings from today's conversation that I took away. A newer type of trial design called adapted trials, which Dr. Binnie mentioned, the REMAP-CAP trial. It really allows for new interventions to be added very quickly to studies to respond to an emerging situation like the pandemic, and also add community sites where the majority of patients are presenting, and really that's where we need to do the research. This was really important during the pandemic to be able to provide patients the opportunity to participate in clinical trials offering the latest medicines. It's also very important for community hospitals to be involved in research and to be able to offer its patients early access to novel interventions and ensure more representative population studies that ultimately produces more relevant findings. For the hospital, it's also important to be part of research to offer cutting-edge therapies and allow for faster knowledge translation of what is learned in these studies. And finally, it is possible to start an acute care research program at your hospital. The Community ICU Research Network that Ali was part of produced a research toolkit for the many community hospitals to be able to start a research program in the ICU and benefit from the knowledge of those that have built research programs over the course of time that have been successful. So thank you all for being part of this conversation, and we look forward to Celebrate Research Week coming up in November.
Thank you everyone for joining us today. We just want to take a moment to invite you to Celebrate Research Week from November 18th to the 22nd. We have a big week planned with keynote talks, a unique art science show. We'll have a research fair at Brampton City Hall and many other events. If you are an artist, please submit your work so we can post it alongside in our research fair. And if you're a researcher, there's a community calendar where you can post your own events. Thank you very much, everyone, for being here for this wonderful talk. We'll see you soon in person in November.